Syphilis is a multi-system chronic bacterial infection caused by the gram-negative spirochete treponema pallidum. And syphilis is divided into acquired syphilis and congenital syphilis. This is known as the great imitator because it may cause a wide variety of not only systemic manifestation but also ocular inflammatory changes. The incidence of syphilis infection around the world is on the rise, with over 90% of which reported in developing countries. In the developed world, a rising number of ocular syphilis with the advent of the heart. The rate of HIV co-infection with syphilis ranges from 20 to 70%. The male gender is the only statistically significant risk factor for the development of ocular syphilis. Systemic manifestation of syphilis can be divided in 4 stages. The primary syphilis, the secondary syphilis, the latent syphilis with the early latent stage and the late latent stage, and the 4th stage is the tertiary syphilis. 1/3 of untreated patients will go to tertiary syphilis if they are untreated. Congenital syphilis may lead to death in 50% of infected cases, and in surviving children may have early congenital syphilis and late congenital syphilis systemic manifestations. Ocular syphilis occurs most often during the secondary and latent stages. Ocular syphilis may be the only presenting feature of syphilis. Ocular syphilis without any evidence for systemic involving. Wide variety of ocular inflammatory manifestation involving the orbit, eyelids, conjunctiva, cornea, sclera, retina, choroid, optic nerve, other neuro-ophthalmic manifestation. Syphilitic eyelid chancre, as you can see, syphilitic scleritis, and this is the typical interstitial keratitis caused by syphilis, mainly observed in congenital syphilis. Syphilis accounts for only 1 to 2% of all uveitis cases, according to many studies. Syphilitic uveitis may be unilateral or bilateral, with involvement of the anterior segment and or posterior segment. However, panuveitis is the most common anatomic form of ocular uveitic syphilis. Why should serological testing for syphilis be performed in any forms of uveitis? Because isolated ocular syphilis is isolated in most patients. There is a wide range of non-specific ocular inflammatory signs. If untreated, there is a high risk for severe ocular and systemic morbidity. We have a very specific and sensitive serologic test widely available around the world, and syphilis can be cured if treated properly. These are the reasons why we should consider syphilis in any form of intraocular inflammation. Anterior uveitis may be unilateral or bilateral, isolated or associated with vitritis, granulomatous or non-granulomatous, iris nodules, poor response to topical steroids. The presence of abnormal dilated iris vessels is highly suggestive of syphilitic infections. Other findings, including gammita, iris atrophy, interstitial keratitis, posterior synechia, and other changes associated with anterior uveitis. posterior segment involvement in syphilis may take the form of intermediate uveitis, posterior uveitis, panuveitis, or optic nerve involvement. Acute syphilitic posterior placoid chorioretinitis, first described by Gass in 1990, is considered to be highly suggestive of syphilis, and as you can see, it takes the form of a solitary, deep, yellowish-white placoid, circular or oval lesion involving the posterior pole. This is very typical for syphilis. Fluorescein show early hypofluorescence and late staining of the placoid lesion. OCT is very useful in the diagnosis of acute syphilitic posterior placoid chorioretinitis, showing some characteristic outer retinal changes, including disruption of ellipsoid zone, nodular thickening of the retinal of the RPE, the loss of outer segment, the RPE junction, and loss of the external limiting membrane with a transient subretinal fluid, and as you can see, complete restoration of outer structure after early and appropriate treatment. Here another case of acute syphilitic posterior placoid chorioretinitis at presentation and after treatment. Another typical feature of syphilitic retinitis is the superficial multifocal retinitis called ground glass retinitis, inner punctate retinitis, generally associated with retinal vasculitis involving arteries and the presence of pre-retinal vitreous opacity. This is very suggestive of ocular syphilis. Retinal multifocal retinitis, multifocal superficial retinitis, as I said before, can be associated with retinal vasculitis. This is a case, a recent case we treated in our department. At presentation, you can see multifocal retinitis with vitreous opacity, pre-retinal vitreous opacity, and retinal vasculitis 4 months after treatment, resolution of retinitis and retinal vasculitis. The syphilitic necrotizing retinitis should be differentiated from viral retinitis, and clues to the diagnosis include the involvement of posterior pole or periphery, the ill-defined margins, the moderately opacified retina, and mottled aspect. However, sometimes syphilitic necrotizing retinitis may be difficult to differentiate from viral retinitis or sometimes from atypical toxoplasmic retinitis. Isolated retinal vasculitis can also occur, and it may be occlusive in nature. Optic nerve involvement may be present in the form of isolated papillitis, optic neuritis, neuroretinitis, or retrobulbar optic neuritis. Optic nerve inflammatory involvement should be differentiated from papilledema associated with acute meningitis. Congenital ocular syphilis, some aspects like multifocal chorioretinal changes and taking the form of pseudo-retinitis pigmentosa in some patients. These changes are not progressive, and the patient may have normal vision. Let me remind you the triad of Hutchinson, including interstitial keratitis, the peg-shaped upper incisors, and sensory deafness. Diagnosis of syphilis is usually made based on serologic testing, including non-treponemal tests and direct treponemal tests. The non-treponemal tests are indicator of both disease activity and of appropriate and complete treatment. These tests are not specific for syphilis. There may be false positive results in some condition, as well as false negative results in early stage of infection. So we need also to perform direct treponemal tests, detecting antibody directed against treponemal antigens, more sensitive and specific indicators of past and current infections, and these tests may remain reactive for years despite adequate treatment. So the diagnosis of syphilis is usually based on the combination of treponemal and non-treponemal tests to confirm the diagnosis. Testing for HIV should be performed in all patients with syphilis, given the high rate of co-infections. The CDC also recommends lumbar punctures in all patients with ocular syphilis to detect neurosyphilis, but this is a controversial issue. Ocular syphilis in HIV-infected patients. Co-infection is common, as I said before. HIV patients with syphilis are more prone to develop neurosyphilis, or ocular involvement is more severe, high frequency of posterior uveitis and more severe posterior segment involvement, and the laboratory diagnosis may be more challenging. Differential diagnosis of ocular syphilis. Ocular syphilis, as I said, should be considered in the differential diagnosis of any ocular inflammatory disease. Management. Ocular syphilis should be treated as neurosyphilis. Penicillin G is the drug of choice for all stages of syphilis. Benzathine penicillin does not penetrate the blood-ocular barrier. The use of corticosteroids is controversial, and new infected patients should be reported to the local health authorities, and sexual contacts of the patient must be treated. The protocol to treat ocular syphilis, the most widely used protocol is the penicillin G, 18 to 24 million unit IV daily for 10 to 14 days, or procaine penicillin associated with oral probenecid. And in the late stage, this regimen will be followed by the benzathine penicillin every week for up to 3 weeks. And in patients allergic to penicillin, ceftriaxone can be successfully used to treat ocular syphilis. HIV patient treatment should be continued for 3 weeks. Monitoring of response to treatment is very important, and we have to check the patient for the development of the Jerish reaction, which is common in syphilis in general and ocular syphilis in particular. So in conclusion, the incidence of syphilis is on the rise globally. HIV co-infection is common, a wide variety of ocular manifestation, but some clinical presentation can be considered as highly suggestive of ocular syphilis, mainly including acute posterior placoid chorioretinitis and multifocal superficial retinal infiltrates and vitreous lesions. Diagnosis based on the combination of non-specific and specific tests. Treatment should be done as treatment of neurosyphilis with penicillin G, the drug of choice for all stages of syphilis. However, but prophylaxis is the main important issue in this infectious disease. Thank you for your attention.
Thank you, Monsef, for presenting this very tricky condition which should never be forgotten in the differential diagnosis.